From the University of Washington in Seattle, the Institute for Health Metrics and Evaluation presents the announcement of the 2020 Roux Prize. Hello, and welcome to the presentation of the 2020 Roux Prize. I'm Angela Poe Russell. The prize is administered here at the Institute for Health Metrics and Evaluation at the University of Washington, and it honors those who have used health evidence in bold ways to make people's lives healthier. And the need for bold uses of health evidence has never been greater. COVID-19 has cost more than 1 million lives, and IHME's forecasts have become this indispensable tool for policymakers as they try to adapt to all the changes this pandemic has forced upon us. In fact, this program is one small example of those changes. It's virtual instead of the live galas that we've done in the past. But what hasn't changed is IHME's commitment to producing great science and recognizing innovation. In a few minutes, you'll get to meet some of the past winners of the Roux Prize, people whose contributions to the field of public health have helped make the world a better and safer place. And later, we'll announce the names of the remarkable scientists who have been awarded the 2020 prize. But before we do that, here's how the prize came to be.
This has gone pretty well.
What first drew Barbara and David Roux to one another was counterintuitive.
It was our near complete lack of common interests that made us so compatible. I was from the north, she was from the south.
Yeah, he's very analytical, I'm not. And
I have no fashion sense. He's very stylish.
But opposites attract, and over the past 38 years, Barbara and David have become parents and grandparents. They've settled on a farm, and they've also settled on their philanthropic priorities.
several years ago, we really discussed between us some of the things that we felt passionate about: the environment, public health, education. And we have developed a better understanding of how we hope to contribute in those three areas over time.
We're, I think, naturally attracted to projects that look difficult, maybe even impossible, but which, if we can help them bring to fruition, can have large, broad-reaching, and profound impacts.
If we switch to looking at years of life lost,
Dr. Chris Murray proposed exactly that kind of project, a comprehensive database of world population health. Dave was captivated and signed on as a founding board member of the Institute for Health Metrics and Evaluation. He and Barbara sponsored IHME's Roux Prize as a means of highlighting extraordinary data-driven responses to public health issues.
We both felt that it was very important to recognize people that are doing very important work in public health, and important to recognize the people that are not as visible but are making very important contributions to this field.
There are public health heroes in every country, in every discipline, doing terrific work all over the globe. And this is a way of kind of shining a spotlight on some of them in order to let them tell their stories and inspire other people who are doing similar work.
Winners of the Roux Prize are awarded $100,000 US and given a medal rife with symbolism.
You can see the threads woven all around, which are meant to symbolize data flowing all around the world. And then secondly, you can see ripples showing the impact radiating out from this central core and touching people and institutions worldwide.
Having a worldwide impact is a defining mission for Barbara and David.
We've been fortunate to live in nice places, enjoy good health, and have access to education, so we know personally how valuable these elements can be, and we'd like to see as many people as possible and enjoy those same gifts.
Well, whether it's improving the lives of refugees on the Burmese-Thai border or fighting for better health outcomes in Rwanda, Mali, and the Philippines, whether it's rooting out the causes of violence in Colombia or fusing the very best elements of science and journalism, one thing all past recipients of the Roux Prize have in common is their extraordinary commitment to public service. Here are their stories. The streets of Cali, Colombia, are where the Roux Prize's inaugural laureate made his mark. An epidemiologist by training, Dr. Rodrigo Guerrero was elected mayor in 1992, determined to use data to tackle the city's high homicide rate.
In Colombia, was 15% of the gross national product was lost because of violence. And there was a time that we were using 6% of our GNP for education and 7% of our GNP for health. So we were losing by violence more than the combined efforts we are doing for health and education.
During 2 spells as mayor, Guerrero reduced the number of homicides drastically by analyzing the causes of murders and then placing restrictions on alcohol and guns, techniques that were copied throughout Colombia and across Latin America. The 2015 Roux Prize recipient, Dr. Agnes Bingawahu, returned to Rwanda shortly after the genocide of 1994, encountering a desperate situation.
When I came back in Rwanda, all the health sector was destroyed, but the entire country was destroyed. Nothing was functioning, no way to get medicine on time.
Bingawahu immediately recognized the value of data and, using IHME's global burden of disease, identified neonatal care and illnesses caused by smoke from wood stoves as priorities for healthcare improvement.
It's not that I'm interested in health data. I'm interested in knowing what I'm doing. And I'm interested in knowing how the world is working. And to know that, you need data, you need science.
Focus on 2 things.
Science is at the heart of John Wong's work.
What is the burden of each of the diseases that are prevalent here in the Philippines?
An epidemiologist and biostatistician, Wong was invited by the Philippine government to help it establish universal health care coverage, using disability-adjusted life years, or DALYs, culled from IHME's global burden of disease. Wong and his team identified the top causes of ill health in the Philippines, pairing them with the most cost-effective interventions.
Complications from prematurity has the 4th highest burden of disease in the Philippines, as measured by DALYs. The cause of this is traceable to poor obstetrical care. So we need better antenatal care, we need better care during delivery, and also postnatal care.
Using data to determine health priorities and affordable interventions in resource-poor environments motivates many Roux Prize laureates. In Mali, one of the poorest countries in the world, Dr. Samba Sow established a laboratory to determine the causes of often deadly infections. Having identified pneumococcal infection and Haemophilus influenza type B, known as Hib, as major elements of the burden of disease, Sow implemented a vaccine program in conjunction with Gavi that reduced deaths from Hib by 80% in 3 years.
If you do surveillance, you demonstrate a high disease burden, and then you maintain surveillance, you introduce vaccine, and you improve some knowledge and skills at the clinic so that they can collect right data, you can save lives.
When conflict erupted between Burmese government forces and the country's Karen minority in the late 1980s, Cynthia Maung, a 3rd-generation Karen doctor, fled to neighboring Thailand. There, she set up a clinic treating other refugees, internally displaced people, and migrant workers. Noticing that their medical records had large gaps, she introduced the Health Information System, collating and computerizing data from all aspects of the clinic's work and emphasizing the importance of including all patients.
I mean, you have to have the standard life for all the people, regardless of the status or regardless of the man, woman, or so we have to make sure that everybody access to essential healthcare through the collaboration and network, but we cannot do alone ourselves.
At the opposite end of the medical data spectrum from handwritten originated records are the Lancet 16-journal family of publications. Under the leadership of Editor-in-Chief Richard Horton, the Lancet has embraced data as the bedrock for unashamedly promoting public health goals globally.
At the Lancet, what we've tried to do is to use the science we publish in two ways. First, as a means for advocacy, to try and draw attention to some of the most pressing health issues in the world and put them into the agendas of presidents and prime ministers. But also we want to hold those with political power accountable for their promises and commitments.
Though their life stories are very different, what each of the Roux Prize laureates have in common is their passion for improving lives by gathering and analyzing health data. Theirs is a mission guided by these words, often attributed to Galileo.
Measure anything you can, and wherever you cannot, make it measurable.
Previous recipients of the Roux Prize are a source of inspiration for anyone who cares about public health. And in just a moment, that roster of achievement will be expanded. Here to announce the winners of the 2020 Roux Prize are Barbara Roux and founding IHME board member David Roux.
Thank you, Angela. It now falls to me, with very great pleasure, to announce the winner of the 2020 Roux Prize. In a departure from tradition, this year's award is shared by two people, sister and brother, whose work epitomizes the values of the Roux Prize, touching the lives of millions of people all across the globe. This year's recipients are academics with a passion for public health that has led them to dedicate their careers to developing an open-source health data management platform used by major global health agencies in more than 100 countries. It is my very great pleasure to announce that the winners of the 2020 Roux Prize are Professor Jørn Roux and Professor Kristen Roux of the University of Oslo in Norway.
Congratulations, Kristen and Jørn. David and I could not think of more worthy winners of this award. Rest assured, we have your medals in our safekeeping and we'll be sending them to you very shortly. Congratulations again.
Jørn and Kristen Roux's impact on the collection of health data reaches into nearly every continent on Earth. How did this brother and sister team of scientists come to touch so many lives? We visited with them in Norway to find out. Jørn Roux is 7.5 years older than his sister Kristen, but from her very earliest childhood, she was a force to be reckoned with.
We always actually have had a very good relationship. I mean, even though I was pretty annoying, I guess, and I know, but we always have a good relationship.
Of course, she was so energetic that it was a bit tiring, of course, when I was young, and embarrassing and stuff like that, but after a few decades, you get used to it.
Kristen, like her older brother, poured her energy into the field of information technology in the pursuit of social justice.
Couldn't really imagine that we will end up working in this big, large grassroots movement. However, we both of us was very political active in the youth. And we both of us was believing in grassroots movement and kind of actionistic take on changing the world.
In the early 1990s, one place where the world was changing significantly was South Africa.
The aim was for the new government in Mandela's government in South Africa was to ensure equity in health services provision, but they had to have data to measure whether that equity was achieved or not. So that was the first purpose of the DHIS2 software,
Norwegian scientists working collaboratively with 2 South African universities developed software called the District Health Information Software, known today as DHIS2. It is designed to monitor the public health needs of individual communities, and through real-time, community-based reporting, an aggregate picture of a nation's public health needs emerges that officials can use to allocate resources. Well, other African countries noticed the South African example, and with the help of Jørn and his colleagues, adapted the software for their own use.
Let me introduce Bjørn, because Bjørn will now show something great, cool features.
Kristen joined the team in 2009 and runs the department which manages DHIS2.
It started off as standalone Microsoft Access software, and then it kind of traveled through geography and technology to become a web-based, cloud-based, mobile internet-based, become actually a platform. So we are actually working on a real implementation and learning from each implementation how to tweak the DHIS2 as a health information system platform for public health into a disease surveillance platform. From the Ministry of
Learning from the use cases and ensuring that those lessons are shared widely among the users is fundamental to the DHIS2 ethos.
Everyone ready for DHIS2 for education?
It's an open source platform that users are free to adapt to the specific needs of their countries.
Countries can start using it without initial barriers of thresholds of cost. In Senegal, with a little help, they started using the DHIS2 for COVID. They already know the DHIS2 for the other health services, but they were able more or less on their own then to train people all over the country, all health centers, via Zoom. If it had not been open source, it would not have been possible.
It's been adopted by health ministries in at least 73 countries, and Kristen and Jørn nurture its growth from their home base at the University of Oslo.
It's very, very important to emphasize that this is a we, this is not us. The role of the University of Oslo is actually, we are coordinating the software development there. We are providing PhD program. So we could say that it's a hub for providing global resources to enable implementations in the local area.
This brother and sister team has helped build a global network of health data covering 2.4 billion people, a third of the world's population. And while working with family can be challenging for some, for Kristen and Jørn, it's an advantage.
We can actually work together very well because we are complementary and we have very, very different personalities. But however, we always kind of form strategies, discuss the big things, and actually agree.
And what they agree upon is the power of locally generated, data-driven solutions to public health issues.
Local empowerment and use of information for action at the local level and measurement for equity in health, that's actually the participatory design principles that is ruling our work even today.
There you come with the apples.
Apples.
Kristen and Jørn's collaborations range from the simplest of things to the most complex. They share a commitment to providing real-world solutions to real-world problems in real time. And in bringing their complementary skills to that task, millions of people the world over are reaping the benefits. Kristen and Jørn Brø's work is helping to facilitate better healthcare management everywhere. So we're taking you to a few key areas around the globe where the Brø's work is making a difference.
Hello, my name is Mark Dezelia, and I currently serve as the Information Systems Team Lead in the Coordinating Office for the U.S. President's Emergency Plan for AIDS Relief, or PEPFAR. It's my great honor, my great privilege to congratulate Kristen and Jørn Brø on their receipt of the 2020 Roux Prize. PEPFAR began its collaboration with the University of Oslo, and of course, with Kristen and Jørn in an official capacity in 2014, when we adopted the DHIS2 software as the foundation of our facility-level data collection and analysis platform, a platform that has allowed this program to ensure that we're delivering the right services to the right beneficiaries at the right times. And it allows us to track our progress towards global HIV epidemic control. Jorn and Kristen have instilled this idea of a system being more than its component parts, knowing a system is, at the end of the day, it's some technology, it's some process, and it's the people. But it has been Jorn and Kristen and the community they've built around its focus on those people that sets DHIS2 apart. That emphasis on what an individual can become in their current role and in a role 10, 20 years from now, and moving this field ahead, that has allowed DHIS2 to be something bigger than software and has allowed people to get engaged and excited about using data at all levels, improving the system and the context around them. It is that spirit that has emboldened me to help our program do more and more challenging things year after year. And I truly, truly, truly want to thank Kristen and Jorn Bra for their contributions to this field, and again, congratulate both of them on their very well-deserved receipt of the 2020 Roux Prize. I can't think of a better brother and sister pair who deserve this award. Thank you.
Let me say a very big thank you to Christine and Jorn Bra, and kindly allow me to extend my thanks to all his team. Since meeting Jorn Bra in 2010 in Accra and Christine shortly after, both of you have become a part of WAHO. Jorn and his team have all traveled to Bobo Dioulasso and to World West Africa to support us in our mission, while Christine has been very instrumental in assembling and managing the team to help us set a regional warehouse and subsequently capacity building on operationalization of the platform nationally and regionally. Today, all 15 ECOWAS member states are using DHIS2 in data management, which has dramatically improved the epidemiological information sharing via regional platform. As an acknowledgement of your contribution, the Director General of WAHO awarded in 2017 this certificate of recognition to honor your team and the important support you have developed in ECOWAS region to supporting the development of health information system. Let me say again, thank you very much and wishing you a very long and blessed life. Thank you.
I would like to congratulate the Bras. Congratulations, Christine Bra. Congratulations, Jorn Bra. I'm proud of you. Wish you the best. And regarding the contribution of DHIS2 in Rwanda, it have contributed a lot. One is that it's now an integrated system that collects data across the public and private facilities. Secondly is that it's now very easier for us to visualize data up to facility level, so we can be able to monitor what happened to the facility. Secondly, it have improved the information used across the layers, which is the facility, district, and the central level. Another part is that it have improved the more focused actions, and again the planning, which is the resource allocations, and it's a flexible tool that you don't need to have programmers for it to be customized. And I also recognize the efforts towards training of training countries to own the system. And this one, that's why I really congratulate the Jorn Bras and Christine Bras for their efforts towards the DHIS2 that is really contributing a lot in the countries. Thank you.
Well, now we are headed back to Norway, where in a few moments, we're going to hear from Jorn and Kristen Bra. And with us to introduce them is a woman who is intimately familiar with the breadth and power of their work. From Oslo, here is the Director General of Norway's Institute of Public Health, Dr. Camilla Stoltenberg.
Thank you, Angela, and good morning to you all from Oslo. It is a true pleasure for me to celebrate the winners of the 2020 Roux Prize, the two professors at the University of Oslo, a sister and a brother, Kristin Bra and Jorn Bra. I nominated these two innovative computer scientists for their outstanding and visionary work in establishing a global system for disease surveillance and healthcare management. The Health Information Systems program, led by the two professors, has made it possible for low and middle income countries to implement a low-cost data system, enabling countries to make the best use of evidence and data for public health. I have seen firsthand how the health information system has provided critical infrastructure for mother and child health in Palestine. I know that DHIS2 has played a crucial role in real-time monitoring of vaccination campaigns in Uganda. And I know that to date, 61 PhD students from the Global South have graduated within the Health Information Systems Program network. These are just a few examples of the bold and fantastic achievements by the two prize winners. So now it is my honor to present the worthy winners, Kristin and Jørn Brå. Congratulations.
So thank you all for these wonderful words, especially to you, Camilla, for actually nominating us. For Tomika from the West African Health Organization and Andrew Muhire from Rwanda Ministry of Health for the great collaboration over the last 10 years. Also, thank you to Mark from PEPFAR to being very, very important, forming the partnership around investing in the DHIS2 as a platform. Been very, very important for us. But of course, thank you to the Roux, Barbara and David, for actually giving us this award. And this award is not for us, as we see it. It's actually an award for the whole community.
Yeah, we are honored, of course, of receiving the award, but the honor is shared with the community and all those that have been working together with us since the early days, the start in South Africa, more than 25 years ago. Actually, 26 years ago today, we started the HISP program as a formal part of the South African Reconstruction and Development Program, where the aim was to uplift the people who were suppressed and suffered during apartheid. And for the health sector, the aims of the RDP, as it was called, was to ensure equity in health and health service provision on the one hand, and on the other hand, to support the integration and decentralization of the new district health systems. In these two areas, information as measurement and as information for action and empowerment were very, very, very important. After many years of work in South Africa, around 2000, the HISP and the DHIS movement went on to spread in Africa, starting with Mozambique. It started with developing master programs, working with the different countries in East Africa and then in West Africa. And focus was on research and education, as well as developing information system to support the health services. In Asia, starting with India, where actually it started there with the first version of DHIS2 already in 2000, but the DHIS2, the web-based DHIS, was started in Kerala in 2004, and from there it went on in Asia to big countries like Indonesia and Bangladesh, but also, say, more smaller countries like Sri Lanka, Laos, PDR, and Vietnam, and Myanmar.
So this spreading through all these countries was actually the stepping stone to the movement that we see today with 15 HISP groups. And these HISP groups are very often led by people that have taken a PhD within the HISP program. So this is just, it's also not only software development and becoming a platform through developing this potential with the mobile internet and open source software and the Android as a point of data capturing. But it's also an action research program where people build their career and their education through this program and later have a career in their home country, in the university, in the ministry, or actually forming a HISP groups. So as to date, we have 15 HISP groups that form these spaces. So people have asked us, how could we respond so quickly to the pandemic of the COVID-19? And that is because of this movement of 15 HISP groups that's already leveraged on the implementation of DHIS2 in the country. There is educated people and ownership in the countries. They use the DHIS2 for health information system. And then innovations like the Sri Lanka started already in 29th of January, 2 days after the first suspected cases come to the airport. They were able to configure an app for a port of entry solution for tracing the suspected cases in Sri Lanka. And that formed the startup with sharing through the HISP groups, leveraging all these countries that already used DHIS2 to be able to, 15 of March, actually launching together with WHO, based on the standard indicators, 4 packages on surveillance of the COVID-19 pandemic. So this is possible because we already worked digital. We are already one big family that we work together with software development, having always innovating to be able to meet the use cases in the local area, and then again bringing that back with software features, but also with capacity, with guidelines and the way of doing it in a good way and inspire each other. So to conclude, it's a great honor for us on behalf of the community to receive this prize. So thank you so much.
Kristen and Jørn Bræ have devoted their careers to promoting data-driven responses to public health crises. Their commitment to this cause has been relentless, and it's a commitment that we share here at the Institute for Health Metrics and Evaluation. Joining us with some thoughts on that is Dame Sally Davis, IHME board member and master of Trinity College, Cambridge.
What a pleasure to welcome to the family of Roux Prize laureates, Kristen and Jørn Bræ. It's a great family who are a network of people whose work uses data in so many different ways to make a difference to health, locally, nationally, and globally. The Bræ's work actually follows and reflects the same principles as the Institute of Health Metrics and Evaluation. After all, the IHME delivers timely, relevant, and scientifically valid evidence to improve health policy and practice across the world. The Roux Prize has, once again, shed a light on the importance of powerful global health data, while the work of the IHME in forecasting trajectories of global COVID-19 shows how data can be used by healthcare providers and public health to make a difference in the broadest sense. We all hope that next year the Roux Prize ceremony will be back at the Guildhall here in London. But our only certainty is that the next winner or winners will, like Kristen and Jørn Bræ and the IHME, be passionately committed to the great purpose of improving population health through the collection and interpretation of the very best data. Thank you.
All right, thank you, Dame Sally. Joining us now are 3 people who have dedicated their careers to the purpose that Dame Sally described. From Oslo, the winners of the 2020 Roux Prize, Kristen and Jørn Bræ. And from here in Seattle, Dr. Christopher Murray, the founder and director of the Institute for Health Metrics and Evaluation. Chris, over to you.
Thank you, Angela. And thank you, Kristen and Jørn, for agreeing to take part in the Q&A portion of today's announcement celebration. Before I pass it over to Kristen and Jørn, I'd just like to say what a great pleasure it is to be able to be a share in this announcement of their winning the prize, both because of their many decades commitments to trying to strengthen health information around the world. And it's something that we share very much at IHME, but also because in terms of the global burden of disease collaboration, we're users of some of their work that they've created, the DHIS2. So both for their contributions and for the benefits that we get from their great work. So let me pass it over to Kristin and Jorn. I'm sure my Norwegian pronunciation is not perfect, but congratulations, and we'd love to hear a few words from you.
Thank you so much. We are deeply honored to receive this prize. Thank you, Dave and Barbara Roux, for giving it to us. Also, thank you, Camilla Stoltenberg, that nominated us. But we are only representatives of the large community behind the DHIS2. DHIS2 is a community and a movement, and we would also say a grassroots movement where we actually are 15 HISP groups, like we have in Oslo, although we are coordinating at least the software from Oslo, but the implementation is coordinated by all the HISP groups around the globe in the global south. So the groups are building the possibilities, and the capacity in countries are done through these HISP groups that most of them, the leaders, has taken a PhD within our program at the University of Oslo. So thank you so much for receiving this prize on behalf of the community.
Yes, thank you, everybody. I would like to add thanks and honor shared with those who actually initiated everything together with us in South Africa in the 90s. And it was actually there, and with the help of local health services, University Western Cape, University Cape Town, and others, we actually this program started and became relatively powerful in being part of the reconstruction and development program in South Africa, where the aim was, what is still the aim, is to kind of uplift the poor, I mean, empowering people, and about trying to achieve measurement for equity, meaning being able to collect and use data which can ensure equity of health service provision and health status across communities and ethnic groups, which was the problem that time then in South Africa. I also post-apartheid South Africa, yes, and I think also it's important to mention that this is also was started as an effort to try out and making more international the ideas of bottom-up system development that we have actually as a tradition here in Scandinavia, and mix that with the activism of the anti-apartheid activists from South Africa. I think it's actually that mixture that made this a success. That's my feeling still 20 or more years after. Thank you.
Great. Well, thank you so much for those comments. Now we're going to go to some questions and answers, and we'll hopefully learn more about the decades of work that you have done and contributed to the world through those the Q&A section. To kickstart the Q&A session, we asked a few of our global collaborators to have a question ready to ask. But if anyone has a question of their own, please send it to the email address below, and I'll ask Jorn and Kristin as many of those as time will allow. In the meantime, let's go to the first question from Dr. Alamnesh Merkuzi, who is a senior public health researcher and the coordinator for the National Data Management Center for Health at the Ethiopian Public Health Institute. Alamnesh, over to you.
Thanks, Chris. I would like to congratulate Professor Jorn and Christy, the winner of the 2020 Roux Prize, were the founder of this DHIS2. This is a well-deserved award for developing a very important and dynamic system, which transforms the health information management and evidence generation platform to the highest level. I do have one question. As in many low resource settings, Ethiopia also have challenges in mortality estimation and ascertaining cause of death. In collaboration with IHME, we are currently working to maximize the use of DHIS2 to improve subnational mortality estimates. However, the DHIS2 system have recorded far too few deaths per 100,000 population than the crude death rates the country or districts are expected to report. Of the 900 health facilities, for instance, which reported last year, the DHIS2 system have death report only 420 of them, and the estimate is very close, only for 20 of the health facilities. So I wonder if you reflect on this issue and propose ways to maximize the DHIS2 system for improving mortality estimation. Thank you so much.
Let me try to reflect upon that issue. Actually, some 15, 18 years ago, I was part of the project to convert the morbidity and mortality reports in Ethiopia into the very early version of the DHIS2, or actually DHIS1, 1.3, it was something, 37 or something. And what was an important part of the findings at that time was actually that the reporting system was quite complex with a very long list of diseases and age and gender breakups, and it was actually quite complex. And I've discussed this with colleagues in Ethiopia just recently, and what I have learned is also that the service reports have a much better completeness than the mortality and disease reporting in Ethiopia. And one reason can be that it's quite complex. You have a list of 2,000 diseases where you tick off for mortalities and for inpatient, outpatient, and of course it's a shorter list for health facilities and health posts, but nevertheless it's quite complex. And what we have done in other countries is to try to, because this is a problem everywhere, that you always want to include all diseases in the disease reporting and in the mortality reporting. But what we have been working on lately is to, instead of report aggregated a big list everywhere, rather minimize the list of aggregate reporting some places and focus on case-based reporting in hospitals and increasingly more places and health centers, etc. So to have good quality, some places where you can actually, in hospitals for example, and can use other methods to find out how representative these data are and in the population as a whole, might be as good as trying to get everything from everybody all the time. So that is, I think, one important reflection. And actually we have been working on the DHIS2 side together with WHO to make a simplified ICD-10 reporting, where you have an easier way to codify, and then you can translate that into the full ICD-10 also later. So that is one thing I think might be something to consider when it comes to morbidity and mortality reporting then. So of course Ethiopia is a complex place to implement and scale system, but it could be that case-based reporting could be done in hospitals and gradually more places, but of course not in the health posts and all facilities. Yeah, thank you. That's my my take on how to solve the problem.
Okay, well, I'm going to intersperse a question of my own from the other questions that are coming in. It would be great to hear how you as brother and sister start to work together. It's an unusual combination in the professional world, and so it'd be wonderful to hear a little bit about how that came about and how you've been so effective as a team.
Yeah, that's a very difficult question. You might say that Jørn was the one that convinced me to study informatics, IT, and then we had a different career path, but we joined forces from the early days in South Africa. Then I was actually in the mobile industry, research and innovation center, being research director, to setting up a research and innovation center in Asia for the Norwegian telecom company, all their Asian operations. When I came back, I said, we need to go mobile. So our closest, I mean, before I was a part of the capacity building program with Jørn, it is the founders together with these guys in South Africa and Western Cape. However, after a while, we went to the DHS2 with using cloud-based, web-based, and so forth. And then when I came back to the university in 2009, I said we need to go mobile. So that in that sense, I was actually working on the DHS2 for mobile, and Jørn, always out in the countries. So it happened to be like I was managing the home base, and Jørn is more the foreign affair, running around in countries, working with ministries. We all work with ministries in the whole University of Oslo. However, it's a long-lasting. We are in there for the long run, and that's where we are working with this capacity building program with all the PhD students, with the 65 in history of that. We are not actually stepping on our toes, but having more different areas. Jørn, you want to add?
No, I mean, I think that is a good way to frame it. I mean, we are close, of course, but not so close that we start fighting over all issues. So that's, but no, it's so I think it's a good collaboration.
And we're sharing the same spirit and believe in the grassroots movement, building capacity locally and working with ministries in country. As Jørn mentioned, the participatory design, working actually building capacities in country to create ownership of their own system, so they can be able to take all the innovations that are done in all the countries to be inspired and share those innovations in order to better their own system. So that kind of network is actually crucial to the success of the DHS2, and that kind of ideology, I would say, information for action and the network of action, we are very much sharing.
Yes, and we are from the same tradition of this way of bottom-up evolutionary participatory design of information systems. So I think that is, so we are sharing the ideology from that area. So yeah, so far so good.
Great, wonderful. Thank you, Jørn and Kristen. Now let's go to Zulfi Bhutta, whose many hats include being chair of Global Child Health at the Hospital for Sick Children in Toronto. He's also a distinguished university professor and founding director at the Institute for Global Health and Development at the Aga Khan University in Pakistan. Zulfi, over to you.
Thank you, Chris. Well, congratulations, Jørn and Kristen. I have a relatively benign question, and it pertains to the potential future use, in your opinion, of the DHIS2 platform for CRVS, vital registration systems in low and middle income countries, who may want to use a single platform for collecting information on events in real time. How do you think this might happen?
So CRS, we would say, is not a technical problem. It's more a problem of governance and organization, because civil registration very often are situated in a different department than, not very often, always. Legally, it's in a home affair, local government, with this civil registration. However, we have a module in DHS2 for civil registration, or we can call it CRVS module. So then you need to collaborate or interoperate with the health and the local government or the department for civil registration. We could use an example as in Rwanda, and we saw Dr. Agnes have gotten the prize before us. She's very famous, and we know her. But Rwanda is a good example of where both birth and death are registered in DHS2. Then, of course, we need to share the data between the local government and the DHS2, and that is done because in local government have a different system. So then the data is interoperable with DHS2. So, for instance, when you do make vaccine registration, then you check with a unique ID per child to the birth certificate in the civil registration in the local government. So then the data is going back and forth, so you can actually check whether the child has been registered before and so on. So it's basically, I would say, a governance issue to be able to implement CRVS within the DHS2. Collaboration with the legal department of legal affair or the local government with the health department on DHS2. And Jørn already mentioned the cause of death registry, and that's also the same. You know, you have the cause of death a module in DHS2, but the death certificate is actually done in the local government. And then, of course, there's a matter of these ICD-10 codes, whether it's people are trained in the good code to understand the codes and utilize the codes. That's more a training issue and not necessarily a technical issue. Okay.
Great, thank you, Kristen. For our final collaborator question, let's hear from Dr. Fatima Mourinho, who was the Director of NCDs and Health Promotion at the Brazilian Ministry of Health and is now professor in the Faculty of Medicine at the University of Sao Paulo. Fatima, go ahead.
Thank you, Chris. Professor Ian and Kristen Roux, it is a great honor to be here. I'm a great admirer of your work. I always thought about what your inspiration was. What inspires you to do such massive work and commit to countries that need support so much? Thank you.
I think the inspiration has not changed so much since I started. I started with all this very long time back as a PhD project. We were studying information usage and comparing between Mongolia and South Africa, and that's kind of continued into this work in South Africa. And I think the inspiration is still the same, namely that you see that working at the grassroots level, developing system and building from there and actually make it, enable it to scale to larger setting and ever larger settings. It's what is inspiring. And also this other issue of being able to try to measure for equity, or what we shall call it. Having data that make it possible to both measure health status, health service provision, and the equity between groups, but also data for decision making, and then all this quality comes in, etc. And the problem or the challenge is that there's always, whatever you achieve, there's always more to reach out for, because we are never there. I remember a very long time back, somebody asked me, what are you doing next year when this system is implemented? And that's kind of a wrong thing to state, because you're never ready. It's always something more to achieve. And that's also a problem, because we see that it's last mile of data quality, data usage, etc. It's very hard to achieve, and it will require a lot of work to really keep this going. I mean, just an issue like denominator data, like what the question from Ethiopia was about, namely that the reports on mortality was not really of any value, because the target population was much bigger than what it was reported, and how can you then start to make analysis? So the inspiration is there for a very long time still, to put it that way.
If I can add, in addition to what Jørn said, we also think that the inspiration is super inspirational, that this grassroots movement has becoming a community with many hundred people that are working for the same cause, and that we see that it works. So it's a little bit the slogan of together we can move mountains. It is possible. It is possible to scale system to the whole country. It's possible to sustain the system over 20 years, or as newcomers coming in with all the learning from all the other countries that are before in the history, so we can learn. So the South-South learning is super inspirational, and that we can see that the collaborative that we are working together, the community, that we actually achieve new results and new innovations. And the last one is actually the response to the pandemic, and to see that the community so super fast could be able to collaborate with global solutions adapted to each country, and each country's flexible solution when it comes to governmental legislation and so forth. It's super inspiring, and as Jørn said, it will never end. There's always new challenges up and coming, for need for new innovations, and to share best practices and knowledges.
So I think we have time for one last question, which I'll take the prerogative of asking, which is, what do you see coming down the path next? What are the next big challenges for both you and for the DHIS2 platform?
I will say that the big challenge is to really find ways to use the data in at the local level, in districts, provinces. I mean, subnational level and national level use of data is a big challenge, and to reach out. I mean, we see the problem that data is there, but to get it together and really provide it in a way that is useful for action and analysis is quite complex. For example, the last few years worked a lot in Indonesia, which is a huge country and with a lot of data, but to get this data together from the local system, from the national system, and actually make it useful at province level, at national level, at district level, and at local level, it's a huge challenge. So finding a way to actually get this amount of data into a useful format, and not to forget again that the problem of denominators, and to get that usefully applied at all levels, that is a big challenge now. And it will be, let's say then now next year, the world is going to have a campaign on immunization against COVID. There we have the problem of scale and massive amounts of data, combined with massive amounts of action at the grassroots level. So that is a typical example of what awaits next. And so how to actually get all this data together is a challenge, but we must address them.
And we are addressing it by having local teams in each HISP groups where we actually address, because in our strategy is actually how to increase and strengthening the data use on each level, all the way down to the community. But touching upon what Jørn is mentioning about the vaccine campaign, is the post-COVID or during COVID coming into vaccine. It's actually the very importance of making the disease surveillance as routine, not like only emergency, but routine. So we can be prepared to other pandemics and other disease surveillance. So this we are working very, very hard on, and we have been we just got the collaborative agreement from CDC US to do research and innovation and implementation on how to make DHIS2 capable of meeting the common challenges when making disease surveillance a routine, but also beyond COVID for the future.
And we can also mention the term zoonosis, which is coming up everywhere now. How to have, go for this one health approach, where you find a way to integrate, say, animal health and human health, and that is getting more and more important.
Great, that's really interesting and a challenging agenda for the future. So I think we have just a few moments left, and it'd be great to hear any closing remarks from you.
Yeah, so again, thank you so much for this prize. I think it's very encouraging for us and for the whole community. And as you have heard, it started already in 1994 as a post-apartheid project, as a PhD project, and continued as a capacity building project. However, now used in over 70 countries in the Global South, now also in Norway, by the way. So it's very, very encouraging for us and the community to receive an acknowledgement from the Roux and from the Global Health Society. And we are very happy and thankful on behalf of the community for getting this prize.
Yes, thank you. I'm likewise happy to getting this honor, and again sharing with the whole network of HISP and DHIS2 activists and users. Thank you.
And ministries, not forgotten.
Wonderful. So let me close by first thanking Dave and Barbara Roux for creating the prize. I think we've had another set of truly remarkable winners to go along with our past winners of the Roux Prize. And I think the whole idea of honoring those individuals like the Bras that have made such a contribution to making the world a better place through health information and through really pushing the limits or the envelope in terms of how to understand the world around us is great. So thank you very much to Dave and Barbara. Huge congratulations to Kristen and Jørn and Bra for what you've achieved, what your network has achieved. We hope that maybe in a small way, the Roux Prize will bring even more attention to your accomplishments and to the DHIS2. So thank you for all of you who have joined for this prize ceremony. Please remember to nominate for next year's Roux Prize. Please submit your nominations for the 2021 prize. Let's hope that the world will be a better place next year with hopefully, as we heard from the Bras, global vaccination underway sometime next year. And so maybe our next event will be in person and not through Zoom. So thank you once again, and congratulations to the Bras.